much, and thank you everybody for coming along. This is my last talk of JaVECCS for this year, and I have really enjoyed being here and being at this wonderful conference for the first time. Again, thank you very much to the organisers and for all of you for having me along. For this last talk, I'm going to be talking a little bit about the acute respiratory distress syndrome, or ARDS, a very severe condition that we sometimes have to treat in critical care, and something that has been the topic of some new guidelines and consensus statements, so something where there's definitely a lot to talk about. This is a condition that we often have to treat in our ICU, and for any of you that were at Dr. Claire Sharp's talk in the previous hour, you will have already met OBI. So OBI is a case that I'm going to be coming back to a few times during this presentation as a really good example of ARDS and how we need to manage this illness. When we saw OBI, he was just on his, he presented unwell on his 7th birthday, so not a very happy birthday for him, and he had bacterial pneumonia as his initial disease process, and he had initially been treated with some standard therapy for bacterial pneumonia. So he was initially showing signs of response to conventional oxygen therapy and intravenous antimicrobial therapy, and then he subsequently deteriorated quite substantially. So he developed signs of sepsis and multiple organ dysfunctions due to his sepsis. Those organ dysfunctions included progressive respiratory dysfunction, and no longer was oxygen therapy enough for him, and he deteriorated to the point where he required mechanical ventilation. And this deterioration in his respiratory function was consistent with the acute respiratory distress syndrome, or ARDS. So I'm going to split this talk into 3 sections, and we're going to meet OBI during those 3 sections. I am going to start with a little bit of pathophysiology of ARDS, because I think that whilst I want to keep this clinical and relevant, it really does actually help to understand both the consensus diagnostics and the management of ARDS if you understand a bit more about what this process actually is and what it represents. I'm then going to spend a bit of time about how we clinically diagnose this condition, and it is a syndrome, so it's not something that we have a specific single diagnostic test for. It's something that is diagnosed with a set of criteria. And then I'm going to talk about the management of the disease, and this is mainly going to focus on the approach to mechanical ventilation in ARDS. So firstly, to discuss the pathophysiology, I would like to bring up the most recent human guidelines, and this is something where in veterinary medicine we do share a lot with what comes from human critical care in this area, although we do have our own sets of guidelines where we add our own veterinary key sort of differences and characteristics into it. But sometimes going back to some of the human material can be very helpful. And I have put up a quite long statement from this new global definition of ARDS from human medicine. This is their definition, but they do pack a lot of really important information to understanding what ARDS is into this quite long definition. So I'll use some nice bolding of the text to make it easy to highlight the bits that I'm going to talk about. So firstly, as you would guess from the name, ARDS is an acute process. This is a process that diffusely affects the lungs, so it's not localized to a single specific area of the lung, but it is a very diffuse process that is affecting throughout the lung, and therefore that helps you understand why it can be so severe. And this is an inflammatory process. So when we talk a bit about risk factors for ARDS later, you'll notice that a common theme is a lot of these are pro-inflammatory diseases. So that makes sense when we understand that this is primarily a process of inflammatory injury happening within the lungs. And I do want to highlight that it is a lung injury as well. So there is actual inflammatory damage happening to the lungs in ARDS. It is not purely a functional phenomenon. It is something that does involve actual damage to the lung. And we need to understand that to understand the expected course of disease. It's not something that you expect an animal to recover from overnight. There is substantial damage diffusely through the lungs when they have ARDS, and that is going to need time and support for them to be able to recover. ARDS is precipitated by a risk factor, and I'm going to go into some more detail on a later slide about the different risk factors for ARDS, but it's not something that happens as a disease in its own right or without something else underlying it. And these are generally severe and pro-inflammatory diseases. So we don't typically get ARDS coming out of nowhere where we weren't aware the patient was unwell beforehand. They're more often patients like Obi that progress through a stage of an underlying illness that worsens. Maybe they develop something like sepsis, although it's not always sepsis, and then this progresses through into ARDS as a complication of it. So a lot of disease processes or pathologic mechanisms are involved in ARDS, and I'm going to go through some of these in a subsequent slide as well. But ultimately, this definition highlights that these inflammatory processes in the lung lead to loss of aerated lung tissue. And that means that there are areas of the lung where there is low or no VQ type VQ mismatch. So I don't know how familiar those terms are to all of you, but what I'm talking about there is there are parts of the lung that are not being well ventilated with air, but are still having blood flow through them. They still have perfusion or Q. So that can lead to some quite substantial hypoxemia. So that brings us to the next part of our definition, which is the clinical hallmarks, or what we see that typically alerts us to this condition happening, are both the hypoxemia that results from the blood shunting through those parts of non-aerated lung, as well as diffuse radiographic opacities reflecting the diffuse nature of the lung injury. However, that clinical presentation may vary a bit between different clinical circumstances. So we might have a dog like Obi that was already receiving oxygen therapy and already had some lung disease, so we have to interpret his course of disease in light of understanding what was going on previously. Whereas we may also have a different patient that has no lung issues develop ARDS, or we might have a patient that was already on the mechanical ventilator for another reason before they develop it. So looking at all of those things and working out what changes you would expect to pick up with ARDS varies between clinical context. And then this is not typically a disease that is diagnosed with histology, and all of the research that looks at histology in this syndrome finds a variety of different findings. So the definitions and the clinical recognition of ARDS does not focus on the idea of getting a biopsy or diagnosing this histologically. It's very much a clinical diagnosis based on recognition of the syndrome. So for those interested in the pathophysiology in a bit more detail, I would recommend this excellent review article from the New England Journal of Medicine, which has been written by some of the big names in ARDS research. And this, I won't go into all of the detail of this quite complicated diagram, but I will point out that it basically highlights some differences between healthy normal lung on the left and the initial or exudative phase of ARDS on the right. So I think the first thing to highlight there is that ARDS is a disease process with several phases to it, and this exudative phase is what occurs early. If we look at our normal alveolus, we can see the key feature that anatomic feature that leads to functional good gas exchange in the alveolus, being that the alveolar space is lined with these very thin type 1 pneumocytes, and then there's a very small interstitial space before the very thin capillary endothelium and the blood flowing past in the pulmonary capillary. So there's a very short distance for oxygen and carbon dioxide to have to diffuse between the alveolar gas and the capillary blood. And that's the underpinning of normal pulmonary physiology. If we look at what happens to this process in ARDS, we can see that up here we have a lot of inflammation going on. We've got our pro-inflammatory cells like our neutrophils and macrophages, and a large number of inflammatory cytokines and other pro-inflammatory processes that are going on in quite an unregulated and excessive way inside the alveolus. And this leads to things including damage to that thin alveolar epithelium, fluid flooding into the intraalveolar space and also into the interstitial space, thrombosis within the pulmonary capillary, damage to the pulmonary capillary endothelium, that ultimately lead to a situation where it's going to be very difficult for any oxygen to be able to diffuse through into the pulmonary capillary blood, and you end up with poorly oxygenated blood. Now, this is the early phase, and I did want to highlight that this is a disease process that progresses through multiple phases. So after the exudative phase, we often see it progressing to this proliferative phase, which can be when healing starts to happen, but there's still not necessarily excellent pulmonary function. We see re-establishment of that normal alveolar epithelium. Our type 2 pneumocytes might start to proliferate to be able to turn back into type 1 pneumocytes, and we get restoration of our endothelium, drainage of our edema, and progression through to a more functional alveolus. So we would hope that it goes through this way and progresses to healing. It can, in some situations, instead progress through further to a fibrotic phase, where we lead to extensive and prolonged proliferation of fibroblasts that turn into a fibrotic, non-functional part of lung that can never recover. We don't often really recognise this late phase in veterinary medicine because essentially these patients remain dependent on mechanical ventilation for a very long amount of time, and often they we have ceased attempts at treating them by the time they get to this phase. But essentially that's the outcome that we want to avoid when we're treating them, and we instead want them to progress through to healing. So how do we clinically diagnose this condition? So, like I said, this is not something where there is a specific diagnostic test. Instead, it's something that we need to be aware of as a possibility in all of our critically ill patients that might, if they develop a new or progressive respiratory dysfunction. If there are signs of new or progressive respiratory impairment in a patient that has a severe underlying illness, it is worthwhile going through the criteria to think about whether this could be ARDS. So this brings me to the latest veterinary definition of ARDS, which was published in the Journal of Veterinary Emergency and Critical Care last year. These are the ARDSVET definitions, and we will see in a moment that these, in many ways, are similar to the human definitions for ARDS, but they have been adapted to be appropriate for veterinary practice. So there are a number of features that are listed here that are important for being able to diagnose ARDS. There are these 4 criteria that must be present, and then there is this 5th optional criteria about airway fluid. So there must be a known or suspected predisposing risk factor. So like I said, ARDS doesn't just come out of nowhere. It happens as a complication of critical illness. So we must be able to identify at least one risk factor. We also know that ARDS is a disease process that's associated with a large amount of alveolar flooding and therefore signs of pulmonary edema. Now, fluid overload and left-sided congestive heart failure are also potential reasons for the acute development of pulmonary edema in an unwell patient. So we need to have some sort of thought process that goes into excluding those other important differential diagnoses before we can confirm a patient as having ARDS. We need the timing to make sense. So that human definition I read through earlier mentioned that this is an acute process. That's why it's got acute in the name. So this needs to develop within a week of the clinical insult that underlies it. And then we said that this is a diffuse process that leads to injury throughout multiple regions of the lung. So we need to find evidence of that diffuse nature on some form of diagnostic imaging. And these new guidelines allow the use of multiple types of diagnostic imaging, and we'll talk a little bit about those and their pros and cons in coming slides. The optional supporting criterion is one that is unique to veterinary medicine. This is not a part of the human ARDS definitions, and it is talking about identification of inflammation in airway fluid samples, so tracheal wash or bronchoalveolar lavage. And that can support the diagnosis, but doesn't need to be found in order to diagnose these patients. And certainly not every patient that has ARDS will necessarily have airway fluid collected, although it might often be quite a good idea, and I will talk about why that is in a coming slide. And then the guidelines move on to talking about the final aspect of diagnosing ARDS, which is we said that it impairs oxygenation, and therefore we need to have evidence of that impaired oxygenation in order to make the diagnosis. But this is where it does get a little bit complex, and there's this quite complex table that can be a little bit confusing in terms of how we diagnose that. So I'm going to leave this oxygenation aspect for a moment, and we will come back to it in subsequent slides. So just to highlight, this is really similar to the human criteria for diagnosis of the ARDS in people. Like I said, they are slightly differently organised, so risk factors and origin of edema are combined in a single sentence in the human guidelines rather than being split into 2 aspects in the veterinary guidelines. But it still talks about this 1-week timing. It still talks about finding bilateral findings on chest imaging, and then there's different categories for looking at different impairment of oxygenation. So let's just go into a little bit more detail on what we might actually identify in our patients to be able to meet each of those criteria for the clinical diagnosis. So risk factors for a start. So we need this to be precipitated by a known or suspected acute predisposing factor. I think one of the bits that when I was first learning about ARDS that confused me a bit is that it can be either a pulmonary disease or a non-pulmonary disease that can be a risk factor for ARDS. And we kind of treat the ARDS that develops from either underlying pulmonary disease or non-pulmonary disease relatively similarly. So you can see here that things like aspiration injury are included as our risk factors. Now, that doesn't mean that every aspiration pneumonia patient has ARDS. It just means that they might be like OB and they might progress from an uncomplicated aspiration pneumonia through into meeting the criteria for ARDS. So you can see here that common things include these highly inflammatory diseases that I mentioned. So as well as aspiration pneumonia, we've got sepsis, we've got pancreatitis, we've got trauma, we've got smoke inhalation. These are all very pro-inflammatory syndromes. And then we have a few other possible risk factors listed in the second table. So these are things that maybe are not as strongly supported by evidence, but seem to be also underlying predisposing factors. And this doesn't mean that these are the only things that could lead to ARDS. They're just the ones that we so far have identified in the literature that can be common factors, common underlying critical illnesses that lead to it. On the very right of this slide is a list of risk factors from human medicine, and you can see that there is a lot of overlap here. And I like this table because it does really directly separate them into those direct lung injury or intrapulmonary diseases versus the indirect lung injury or extrapulmonary diseases. And you can see in human medicine, there's very much the same sorts of underlying risk factors in both of those categories. The second thing we need to do is that we need to exclude left-sided congestive heart failure and fluid overload as potential causes. And what are our most accessible ways to do that in veterinary medicine? These really, I think, using point-of-care ultrasound techniques is what's going to be most applicable to most ICU patients. Now, I do want to point out that you want to rule out congestive heart failure and fluid overload as the main causes of your signs. You're wanting to basically be pretty certain that it's not that your patient is just in heart failure or just fluid overloaded, and that's why their respiration is worsening and that's all there is to it. Some of these patients might have some cardiac disease. Some of these patients might be a little bit fluid overloaded when they develop ARDS, and those findings don't stop us from diagnosing ARDS. We just want to make sure that it's not entirely explained by heart failure or fluid overload. So the images here are showing the sort of standard echocardiographic view from the right parasternal short axis window that we might want to obtain to be able to look at the left atrium to aortic diameter ratio. So here you can see that we start at this this transverse view through the left ventricle, and then as we fan up, we get our LA to AO view. If you're going to practice getting one echocardiographic view in the ICU, I would strongly encourage you, if you don't already, to learn how to assess the left atrium to aortic root diameter ratio. This is something that can be a really powerful tool in a lot of situations in emergency and critical care. So this example from textbook that shows you how to get the view shows also a relatively normal ratio where the left atrium should be around 1 to 1.5 times the aortic diameter. On the right, this is an example of an echocardiographic image that would make me stop and really think twice about whether I can diagnose ARDS in this patient or whether the clinical signs might actually be better explained by left-sided congestive heart failure or fluid overload, because this is an extremely enlarged left atrium where you can see that the diameter of the left atrium is over 2 times the aortic diameter. So we've got a LA to AO ratio of 2.06 here. So that's a sort of finding where it would really challenge your ability to diagnose ARDS. Other things that you can look at with point-of-care ultrasound if you're trying to exclude fluid overload as your cause of respiratory signs also include looking at the caudal vena cava. And there have been some other speakers already this conference that have mentioned this technique, so I won't go into all of the detail about it. But one of the easiest sites to assess caudal vena cava diameter is through the subxiphoid view, looking at it as it crosses the diaphragm. And we can both look at it statically, as in terms of just how fat or full it looks, but also look for respiratory variation in its size. And a very distended vena cava with lack of collapse during the respiratory cycle might make us think about fluid overload potentially being a factor here, and we would have to be careful about being sure whether it was fluid overload causing our respiratory signs before we diagnosed ARDS. I have just also put up from the human review a few other conditions that can potentially be differential diagnoses for ARDS, other than the congestive heart failure or the fluid overload. These in general are things that I would consider either not recognised or rarely recognised in veterinary medicine, especially in the context of a patient like Obi that fits with the quite classic progression of ARDS. A known risk factor deteriorates within that 1 week time window, but it is worth thinking about that there are other disease processes that might occasionally come up that might look like ARDS. I think the ones that out of this whole list, the ones that I have seen very occasionally trip people up in veterinary medicine are interstitial lung diseases like interstitial pneumonias or fibrotic pulmonary diseases and pulmonary neoplasia. So those, remember that there are other disease processes, but they're not very common. And then, like I said, we need this to occur within a week of the known clinical insult. So we're really looking at this in our sort of cohort of critically ill patients. And conceptually, I really like to bring up this paper quite often. It's over 15 years old now, but this is a paper that when I read it during my residency really changed a bit how I think about critical care. And it's called Critical Illness is an Iatrogenic Disorder. Now, that might seem a little strange for people who haven't thought about that idea, but the point here is an animal that gets sick enough to have critical illness and be a patient like Obi with ARDS on the ventilator would never have survived to that point without the interventions of medical management prior. So as well as factors to do with the actual underlying disease itself and the host response to illness, what we do in terms of management of the earlier disease really strongly affects what happens in terms of the development of these critical illnesses. And we will touch a little bit more on that as we go on, but this is a complication of critical illness that we can try and avoid by optimizing our treatment of that underlying critical illness. So our next criteria for the diagnosis is to demonstrate pulmonary infiltrates diffusely using some sort of diagnostic imaging. And this is where the new veterinary guidelines differ a little bit from what was said in previous veterinary guidelines in the human sphere, is that the word bilateral used to be used quite a lot, trying to demonstrate the diffuse nature of the lung disease by having to diagnose it on both sides of the chest. That bilateral aspect is no longer as emphasized in the new veterinary definitions. There just has to be some evidence of the diffuse nature of the lung disease. So it's not only affecting the parts of one localized focal part of the lung. So these images are from Obi's CT scan, and CT is a very sensitive and very excellent tool for diagnosing and assessing the severity of lung disease such as ARDS if it's available, but there's a lot of caveats on it. It requires sedation or anesthesia. It often requires quite a distance of travel from the ICU to where the CT is located. It's quite expensive, but it can demonstrate the disease process very nicely. So we see a couple of things on OB-CT. We can see some marked consolidation of the lungs ventrally, bilaterally, and this is probably mainly a sign of the underlying original disease process, the aspiration pneumonia itself. But we can also see diffusely through the remainder of the lung parenchyma, as indicated by this red oval, there's patchy opacities and evidence of lung disease in all sorts of other areas that are not affected by this severe consolidation from the pneumonia. So those are the types of findings we're looking for on lung imaging when we're trying to diagnose ARDS. Now, CT is not necessarily going to be available for every case, and thoracic radiographs, whilst they still play a role, also carry their own technical challenges in patients like OB. In our hospital, to get thoracic radiographs, we need to travel almost as far from the ICU as we do need to get CT, and with a 70-kilo dog on the mechanical ventilator, it's not something that we can do every single day to assess his disease process. And in some settings, access to CT or radiographs is not available or is not easily available. So something that the human and veterinary guidelines talk about in the newest iterations is the role of point-of-care ultrasound in the diagnosis of ARDS. And appropriate sonographic findings are also now considered acceptable for the diagnosis of ARDS. So here I have two images of ultrasound that kind of match up with the two different areas we were seeing in OB's lungs. The one on the left is from a textbook. It's not actually from OB, although his findings were very similar to this, where you have consolidation of the lung, or we might call this hepatization, which matches with the findings of his lungs ventrally. But in this right image, we can see a large number of B lines in the lung, which is coming from what we would see more dorsally in OB's chest. So finding diffuse evidence of pulmonary infiltrates with findings such as severe B lines or consolidations on point-of-care ultrasound is an acceptable way to meet the criteria for diagnosing ARDS in animals. And then finally, like I said, the airway fluid findings are an optional criterion in veterinary medicine, but I do think that there is quite a lot of value in sampling airway fluid in many cases that we have ARDS, and especially most of these cases are going to be intubated and ventilated for their treatment, and sampling airway fluid periodically during this treatment is a really good idea. So this image from OB's airway fluid can show you the very characteristic severe neutrophilic inflammation that we expect, but it also helps us assess for the presence of pulmonary infection. And this might be present from the beginning as an underlying trigger for ARDS, and development of a resistant infection that's not being adequately treated with the antimicrobials we're providing might be even more so a trigger for ARDS. So the finding of worsening amounts of bacteria on airway cytology despite antimicrobial treatment might prompt us that there could be a new resistant infection, and we might need to empirically make a change in antimicrobials and reculture the airway fluid. And that is in fact something that we did need to do with OB, and I think that it's unlikely that we would have got a successful outcome if we didn't appropriately treat the multi-drug resistant infection that he subsequently developed. And then finally, I alluded to the complexity of diagnosing ARDS based on the severity of pulmonary dysfunction. And that's really because how we assess the oxygenation of these patients is context dependent on how we're treating it. So we're never going to diagnose ARDS in a patient that is not receiving some form of oxygen supplementation, because they're going to be in severe respiratory distress, and we must provide some oxygen supplementation in some sort of way to the patient to stabilize them as we're making this diagnosis. And many of our patients are going to be mechanically ventilated by the time that we put together the evidence to meet the criteria for ARDS. That doesn't mean that they didn't already have ARDS before they were on the ventilator. It's more a practical thing, right? That before we can reach the point where we've ticked all the boxes on the criteria, we've needed to stabilize our patient, and we've ended up with them on the ventilator to stabilize them before we meet those criteria. So if we are on the ventilator, we need to have a positive end expiratory pressure, or PEEP, of at least 5 centimetres of water to be able to diagnose ARDS. And I will talk a little bit more later on about the role of PEEP in ARDS, but essentially that is something that you would, if you're appropriately treating, you would always have at least that much PEEP in a patient that could have ARDS. And then we make our assessment based on the severity of their hypoxemia whilst receiving that treatment. And our patients on mechanical ventilation might be receiving a range of different FiO2 or inspired oxygen fractions, so we need to use a measure of oxygenation that accounts for that. So if we're doing arterial blood gases, we use our PaO2 to FiO2 or PF ratio. And if that is between, normal for that is 500. So that should be a PaO2 of 500 millimeters of mercury with an FiO2 of 1 as one example of how you could get a PF ratio of 500. So you need to be less than 300 on that to be able to diagnose ARDS at all. And a PF ratio between 1 and 300 is what we would call mild to moderate ARDS, and less than 100 is severe ARDS. So we can't necessarily do arterial blood gases in every single patient we see. We might not have the facilities for it in our hospital, or we might struggle with getting arterial access for sampling in some of our smaller or more hemodynamically unstable patients. So therefore, these new guidelines also introduce the ability to use the SpO2 to FiO2 ratio, or the SF ratio, with different cutoffs for what diagnoses mild to moderate or severe ARDS. And those are based on research on these ratios in small animals. You will see that the SF ratio have the caveat that SpO2 must be less than or equal to 97% to be able to use that measure. And the reason for that is just because of the shape of the oxygen hemoglobin dissociation curve. So whilst our PF ratio is our gold standard, our SpO2, if accurately measured, is a quite good surrogate of PaO2 that is quite linearly related to it in a large portion of our hemoglobin oxygen dissociation curve. But at high SpO2, that curve really flattens off, and we lose the linear relationship between SpO2 and FiO2. So that's why this measure is only valid at an SpO2 of less than 97%. As you'll see as I talk about the appropriate management of an ARDS patient on the ventilator, we're very often going to be sitting at a SpO2 of less than 97% in these patients. And if you're getting SpO2s of 100%, it may well be that either you don't have ARDS at all, or you need to reduce some settings to reduce the aggressiveness of your ventilation as you are oxygenating them more than we may need for this condition. And then there are a range of criteria that talk about non-intubated ARDS, allowing for the fact that some of these patients we are able to treat, especially with the emergence of high-flow nasal oxygen. Some patients with mild to moderate ARDS may actually be able to survive this disease process without mechanical ventilation and be able to survive the whole thing with high-flow nasal oxygen. So there's just a minimum requirement on the flow rate for the nasal oxygen, high flow. And then it also does allow for diagnosis on traditional oxygen therapy. However, it is unlikely that a patient with true ARDS would be able to stay on traditional oxygen therapy and survive that disease process. And then with these criteria in place, there are those same oxygenation measures of the PF and SF ratio. So what have we gone through so far? We've gone through a number of clinical criteria that if we tick all of those boxes, we can say our patient has ARDS. Now, we haven't proven that those histologic features that may or may not be present are there. We haven't done a biopsy. This is very much a clinical diagnosis of a cohort of patients that meet the criteria of this severe pulmonary complication of critical illness and therefore would benefit from the appropriate treatment strategies directed at it. And when I say appropriate treatment strategies, I like to think about this Venn diagram I showed before from the paper on critical illness being an iatrogenic condition. So we want to make sure that we support vital functions of the body adequately whilst not worsening the underlying disease process. So we need to, in order to treat this condition, identify and treat whatever is causing it. So if it's due to sepsis, we need to treat the sepsis well. And Dr. Sharp gave a great talk earlier today on treatment of sepsis. So all of that stuff is really important. But as well as treating that, we need to achieve an adequate arterial oxygenation for our patient to have adequate tissue oxygenation, whilst at the same time limiting the amount of further damage that we do, because we have the great potential to do a huge amount of damage to a patient's lung with a mechanical ventilator. So we need to use it in a way that keeps the patient alive and limits that amount of damage. So in terms of removing underlying cause, I think I've probably gone through this adequately. So we want to really look for sepsis because that's very common and it requires specific management as per sort of the guidelines of sepsis management, including antimicrobial therapy and all of the other points that Dr. Sharp talked about earlier today. Or if you didn't go to that talk, you can consult human references such as the Surviving Sepsis Guidelines that are great to extrapolate to veterinary medicine. So we need to make sure that we, as adequately as we can, treat the underlying cause. Then I said we need to achieve adequate arterial oxygenation. And again, I do apologise for having to go to some physiology, but this really underpins critical care in terms of working out what adequate oxygenation is. Because actually it is not the SpO2 or the arterial oxygen saturation of blood in isolation that a patient needs to be some certain number. What we actually care about for our patients is that their organs and their tissues can keep working adequately. And for tissues and organs to function adequately, they need to be delivered enough oxygen. So our tissues are what need oxygen. And yes, our lungs are very important in getting the oxygen into the arterial blood. So arterial oxygen content is really affected by the saturation of hemoglobin and a little bit affected by just pure dissolved oxygen in the blood. And our lungs are the main driving factor of those. If we have lung disease, how we manage the lung disease affects our arterial oxygen content. But this works in combination with a number of different factors to be able to get that actual oxygen to the tissues. So you also need to have enough hemoglobin or an adequate hemoglobin concentration. Cardiac output is important, which is affected by a number of things. Actually, perfusing blood through the tissues requires a blood pressure that relies on systemic vascular resistance. And our critically ill patients may have abnormalities of multiple other factors on this tree of life as well. And what we pick as our oxygenation target might vary based on how many other things are abnormal. In a patient where most of the other things here are normal and their tissue requirement for oxygen is kind of the average that we'd expect for a sedated or anesthetized ventilated patient, we can probably get away with an SpO2 down to about 88% or a PaO2 of about 55 millimeters of mercury. And we might not aim any higher than that because we think that is adequate in order to get our tissues oxygenated enough whilst avoiding the harm of more aggressive treatment. But that might not be true if we have a patient that also has septic shock and vasodilation, or has some myocardial dysfunction and reduced cardiac output, or is anemic, or has a type of disease process where the tissue requires a little bit more oxygen to be delivered, such as a brain injury. So we might adjust our oxygenation target based on the concurrent abnormalities in a patient. So some patients, yes, you can pick 88% SpO2 as your target, that you just want to reach that for ARDS, but not all of them. Some of them require higher targets. And why might we aim for such a low target? Because we can definitely, like I said, do a lot of damage with our mechanical ventilator. So if we over-distend alveoli, we can damage them quite substantially. Mechanical ventilation leads to release of inflammatory mediators that further can worsen inflammatory injuries. If we are allowing our alveoli to collapse and pop open, or cyclic recruitment, derecruitment every time we ventilate, that can cause further damage. And oxygen itself is toxic to the pulmonary epithelium and can lead to oxidative stress and injury that can worsen damage. So we want to limit all of these things to only what is needed. So just as a little side point, I have just popped in a slide about high-flow nasal oxygen therapy because, like I said, this is emerging as a more and more utilised treatment in veterinary medicine, and some mild to moderate ARDS patients may be able to get away with this as their treatment. And we learnt a lot from human medicine during the COVID-19 pandemic, where people were treated with this sometimes because mechanical ventilators weren't available, and they would have previously gone on to ventilation if there was a ventilator available, but they had to make do, and actually those people did surprisingly better than a lot of doctors expected. So this can be a viable treatment option, potentially for the whole disease process during some of the milder cases, or as a bridge from mechanical ventilation sometimes as well. But like I said, most cases of ARDS, we do end up with a patient on the ventilator like Obi. So what do we need to do in order to adequately oxygenate them whilst minimising our ventilator-induced or ventilator-associated lung injury? And what we have really taken from human medicine, there's not too much data in our own species to really support this, but we have extrapolated a lot from human and experimental data, is this idea of lung protective ventilation. And what lung protective ventilation involves is lower tidal volumes than we might use during conventional mechanical ventilation, allowing our patient to be a little bit hypercapnic, what we call permissive hypercapnia, and trying to achieve our oxygenation targets by using more positive end expiratory pressure, or PEEP, and less inspired oxygen fraction, or FiO2, that recognising the detrimental effects of oxygen toxicity. And overall, we're trying to limit the amount of positive pressure that we apply to the lung to only what is necessary to achieve adequate oxygenation. And I'll touch a little bit on this idea of driving pressure, which is the difference between the plateau inspiratory pressure and the positive end expiratory pressure, as it does seem that a lot of the research is supporting that that is the crucial pressure gradient to minimise if we're trying to minimise ventilator-associated lung injury. So in terms of tidal volume, when I say small, what do I mean as small tidal volume? If you read the human ARDS guidelines or treatment recommendations or papers about lung protective ventilation, you'll find this target of 4 to 6 mil per kilo as what they treat as small tidal volume ventilation. And this is just, dogs are not small people, cats are not small people. This is just not a target that is often, 4 mils per kilo is just not going to be adequate ventilation for pretty much any dog. We generally just can't get away with those types of extreme small tidal volume. So when I'm doing lung protective ventilation in a dog or a cat, I'm generally more aiming for somewhere in the 6 to 8 mil per kilo range to be able to achieve acceptable levels of CO2. We still allow some hypercapnia, the permissive hypercapnia, but we just need to have a bit more of a tidal volume to be able to overcome the greater airway dead space that our species have. Now, like we say, this approach, limiting the tidal volume, will cause the CO2 to go up. So what can we do about that? We can accept a higher CO2 and allow our patient's CO2 to be a bit higher if it doesn't seem to be causing any complications. Again, that's very patient-specific because the main acute complications we see in a critically ill patient of a respiratory acidosis are worsening cardiovascular status, and it can certainly make our systemic vasodilation and our response to vasopressor agents worse. So in a patient that's hemodynamically stable, we might be able to tolerate a higher CO2 than a patient that's in septic shock, like Obi was. The other thing that we can try to do to limit our degree of hypercapnia is increase the respiratory rate, because remember, minute volume, or the total minute ventilation of the lungs, is the product of tidal volume and respiratory rate. However, there is some emerging research that is showing that increased respiratory rate is also traumatic to the lungs and increases the biotrauma, the pro-inflammatory nature. So we can't just freely set as high a respiratory rate as we want and still think that that is necessarily going to be lung protective. The other thing that I mentioned about the hemodynamic instability and that limiting our ability to tolerate higher CO2, brain disease and brain injury is definitely the other cohort of patients where we might aim for a stricter CO2 target, or we will aim for a stricter CO2 target. Those injured brains are not able to cope with the vasoactive effects of excessive CO2 on the cerebral vasculature. Then when I'm talking about achieving adequate oxygenation, I alluded to before the approach of using a higher PEEP and a lower FiO2. So in ventilation of lung disease, both of these factors can increase your arterial oxygen saturation and your PaO2. So increasing the FiO2 just increases the fraction of oxygen in the ventilated alveoli and therefore can increase the amount of oxygen in the pulmonary capillary blood. That's probably relatively intuitive to most people. Positive end expiratory pressure aims to improve oxygenation by re-expanding collapsed alveoli and reducing the amount of ventilation perfusion mismatch in the lungs by allowing alveoli that were previously just shunting blood past no gas to be able to participate in gas exchange again. But we need to make a compromise, and like I said, in general, most of what we know supports that a higher PEEP, lower FiO2 type strategy is likely to be more lung protective in ARDS. So this is an example of a table that might be used as it's written in human medicine. Some human hospitals will use these tables from the ARDSNet guidelines to specifically titrate PEEP and FiO2 in order to meet their oxygenation targets. So what they'll do is they'll set a target for their patient. Like I said, if all of the other aspects of the tree of life are okay, that might be something like a PaO2 of 55 and an SaO2 of 88%. It might be a higher target for some patients, and then they just adjust PEEP and FiO2 based on one of these strategies, with the evidence generally pointing towards higher PEEP strategies being better. Although you can see here that for many of us in veterinary medicine, both of these strategies still involve quite a lot of PEEP compared to how we might mechanically ventilate a patient that doesn't have ARDS. And as I alluded to before, the main pressure gradient that is thought to be associated with ventilator-associated lung injury is the driving pressure, which is the difference between this PEEP and the plateau pressure during inspiration. So higher PEEP strategies and then limiting the amount of increase in positive pressure during inspiration and titrating to find the set of pressure settings that minimize this pressure gradient is emerging as a strategy for picking the ideal ventilator settings. We don't know what the ideal ventilator settings for dogs and cats with ARDS are. This is all just extrapolating from human and experimental research to give some ideas of what we might try. For any individual patient on the mechanical ventilator, they can be quite individual, and we might just need to tweak settings and use things that seem to work for our individual patient, but this gives a starting point. I'm almost out of time, but I did just want to mention some of the other things that you might need to do in the most severe cases. You might need to do things like use advanced modes of ventilation, like airway pressure release ventilation. I'm not going to go into details on how that works. And we might choose to also use things like neuromuscular blocking agents to improve our patient ventilator synchrony. That's something that Dr. Sharp alluded to in OB, but I don't really have time to go into in detail. The other thing, just because probably most people that have seen me speak before know that I can't get through any talk without at least throwing in a couple of slides about intravenous fluid therapy, so I just popped a couple of intravenous fluid therapy slides in at the end. The other thing that we want to try and do is make sure that we maintain ideal fluid balance in these patients, because essentially any additional fluid overload might more readily manifest as pulmonary edema in these patients that have inflammatory lung injury. So I often talk about acute kidney injury, so I use this graph on the screen in acute kidney injury talks, but I think the same concept is absolutely true for ARDS as well. When you have a healthy patient, they're much more tolerant of either hypovolemia or hypervolemia. But when you've got a sick patient, any small amount of fluid overload or hypovolemia can cause quite substantial damage. So maintaining good critical care, good fluid balance is also a cornerstone of the treatment of ARDS. Now, in terms of what else can we do, are there any drugs that we can give to treat ARDS? It's something where we would love to have a medication that can improve outcome, but like many of these complex multifactorial critical illnesses, a lot of the research into such medications has gone nowhere. The one that comes up a lot in critical illness that's still controversial and in discussion is whether corticosteroids might play any role in ARDS. And essentially what we generally do in these cases is that we just use them for the other aspects of their critical illness as indicated. So for example, a dog like Obi ended up needing some hydrocortisone because he had vasopressor-resistant septic shock, but there's no clear indication for ARDS alone for use of corticosteroids at this time. But it may sound horrendous, and you may think, is there any hope? So this is Obi on his 7th birthday, and then this is Obi on his 8th birthday. He spent 1 week on the mechanical ventilator, several weeks in hospital. He had multiple additional complications of his multiple organ dysfunction that I won't go into detail from, but he survived, and he is still happy, healthy for an elderly Great Dane dog today. So thank you very much for listening, and if anyone has any quick questions, I would be happy to take them.